This is Jill with Go Long, where we sit here and we dispel BS and myths so that this way women 40 plus can get the healthcare and the information that they need to live their best lives going forward. Your life doesn't have to be over because you have hit midlife. So with me today is Dr. Tiffany Hollenbeck. Just want to remind everyone that the advice given here does not constitute a patient-provider relationship and is for informative purposes only. You should always check with your healthcare professional before starting any health and wellness program. And Tiffany, why don't you talk a little bit about your background and what you do and how you got to this point?
Well, so I am a medical optometrist, which means that I do glasses and contact lens prescriptions and routine eye exams, but I also see all of my diabetic patients, glaucoma patients, macular degeneration, all the big diseases. And I, from the beginning, all the way back in optometry school, I kind of gravitated towards the medical side of being an eye doctor. But I do still like the glasses and contacts because it's a immediate gratification kind of deal. Like, which is better, one or two? And when somebody's eyes light up because they can see, it's a great feeling.
Sure, that has to be fantastic.
Oh, it's so great. Or when the glasses come in and you put it on that 12-year-old and they see all the leaves on the trees and they hadn't even realized that they were missing them. It is a fantastic feeling. But then there's the medical side too, that becomes a little bit more complicated because the eyes are just part of a big, huge system. And so I do a lot of diabetic discussion, what we should be eating and we shouldn't be eating, and why it's important to take your medications, what happens with the blood vessels specifically in our eyes. And being a teacher kind of at my core, I like to do that with patients, and I hope they take something away from their eye exam that's not just eyeball related.
That's fascinating. So, when you talked about diabetes, are you talking about both type 1 and type 2?
Absolutely. So diabetes is really a disease of blood vessels. And how I explain the blood vessels in the eyes, they're so tiny that they don't stretch quite as much as like your big, huge carotid artery where it's thick and muscular and it can take on a lot of blood flow. And sugar is a really big molecule. And if you're not digesting, you don't have enough insulin in your body to digest the sugar you're eating, this big, huge molecule starts to collect in your blood. So your blood volume increases and the carotid just expands and takes care of all that. But as the blood shuttles into all your tiny little vessels, like your fingertips, your toes, your eyeballs, those vessels will stretch and stretch and stretch until they just can't anymore. And then they pop. And you get these tiny little hemorrhages that start occurring all over in the eye. And I can't go in there and fix them. I can only tell you you have them. But it tells me that you also have them in your fingers, your toes, parts of your brain, your kidneys. It's more of an indicator of how your body is doing.
That's fascinating because as you were talking, is that also a reason why with some diabetics that leads to amputation?
Correct.
Okay.
Yeah, because if you're not getting blood flow to those endpoints, you get tissue necrosis, and that tissue necrosis is horribly painful. And eventually the tissue starts to actually become dead tissue. And so they have to amputate.
Wow. Okay. All right. That's really helpful. So now, obviously, when you have women who are in midlife, they tend to be gaining more weight. They talk about menopause belly. But is there something that a woman going through midlife has to be thinking about as they're putting on weight that could definitely put them into this like pre-diabetic phase that you counsel them on? Is there any link to that?
Well, I talk about we kind of just have to be a little bit more careful about the amount of sugars we process. And I think what's hard about that is sugar's everywhere, but there's good sugars like some fruits, but there's also sugars that, your French fries.
Right.
Anything that's a carbohydrate breaks down into sugar. And so even if you looked up low glycemic foods, even some fruits you don't want to eat, and you can eat a whole plethora of other ones that won't raise your sugars. But yeah, in general, as we go through midlife, and our insulin is a hormone, and so it's part of that whole hormonal process. We want to be a little pickier about the types of carbohydrates and the amount that we eat.
Wow. Okay. So that's something I did not know. So this is really great information. All right. So let's maybe go into some basics here, because I know there's opticians, there's optometrists, and then there's ophthalmologists, and I know there's specialists. Maybe you can just talk about what the difference is between the three and when you would see each of the three.
Yeah, so kind of in the step ladder, we've got opticians first, and they are the ones that when you go in with a glasses prescription, contact lens prescription, they will fill that for you, but they're very good at explaining and educating you on what type of lenses are available. So if you have a prescription that says you're nearsighted of a -2, that's how it's written, they're going to help you select the frame that is going to be best for your face so that your optical center, your best vision, is lined up with your pupils. And they'll also explain things like, do you want scratch coat? What material do you want? Do you want a blue light filter? Are you on computers a lot? Because if you are, you should have that. And so they're a wealth of information when it comes to the glasses and contact lens purchase and fit. And then when you get into optometry, there's a very wide range. There are doctors who have memorized every single curvature of every single contact lens. They look at your eye, they take one measurement, like, this is the lens for you. And that's their goal. They want this perfect glasses and contact lens fit. They do a routine eye exam where they look for any diseases or anything that they're worried about. And sometimes they'll treat that, and sometimes they'll pass that on to a colleague. So then there's the medical side of optometry, which is where I lived for most of my career, Harborview in Seattle and Valley Medical in Renton. And that's when primary care physicians write a referral and they refer it to you because they have diabetes, or urgent care sends you a patient because they have a big red eye and they can't really see what they need to see at their clinic. Or from the ED, we get trauma, motor vehicle accidents, whiplash, that kind of thing. And so we're treating the diseases of the eye. Then when you get into ophthalmology, ophthalmologists are surgeons. And so let's say you have cataracts, and a lot of surgeons work with optometrists. So the optometrist will screen the patient and say, ooh, your cataracts are ready for surgery. And then they send them to the surgeon, and the surgeon does their exam, their measurements, and they'll take the cataract out and put in a new lens. And that's a cataract exchange or lens exchange. But when you get into ophthalmology, you're getting into all the surgical side of it.
Okay. So the optician conversation is interesting. Would you say, like, a lot of people use Warby Parker? They go get their glasses. So where do they they sound like they're kind of on the optician side, but.
Yes. I'm not sure if Warby Parker has like brick and mortar stores that optometrists are in, but usually the patient already has their glasses prescription when they walk into Warby Parker or go online. The measurement that's the most important, like if you're trying frames online, like just virtually, you want to make sure that your optical center, your pupil, is lined up with the optical center of where they make the lens. And so an optician is going to go in there and they'll even line up and put little dots on the glasses and the fake lenses to make sure that they know the measurement of where that's going to be. So for me, I prefer to have an optician actually make those measurements than to do something online. But I've heard good things about some of the online stuff too.
Yeah, I mean, it's all like your comfort level. So that's helpful. So then progressives, that's a very hot topic amongst my friends. And my husband, he got progressives and it never took for him. Like they just never took. So in talking about, like, how do you find the right glasses? How does that work? What would you advise someone who's just been told, like, all right, you're at the progressive stage.
Yes. So when you look straight ahead through your glasses, that's where they're going to line up your distance prescription. And then there's this drop zone down to the frame that gradually changes into your reading glasses.
Mm-hmm.
And all of us at some point need some form of that. There's one eyes up close, and they can get away living life without having to do a progressive. But most people will do progressives or a bifocal, or on and off of two separate pairs of glasses, one for driving, one for reading. The trick with those is when you find a good optician, very knowledgeable, or your optometrist will tell you this too, the pattern of the lens can change. So the original pattern way back 30, 40 years ago was absolutely the hourglass form. So you had a big distance, hardly any for computer, and then big reading. We also weren't on computers that much 30 or 40 years ago. So now, and then everything off to the side is distorted in order to keep the central part clear. So the people who are best with progressives are going to point and shoot their nose wherever they look instead of keeping their head still and only looking with their eyeballs.
Yeah, that's the feedback that I got, is that you have to make those like distinct and intentional movements with your face, and you can't just like kind of scan.
Yeah.
Which makes it challenging for people who work with like in tech. We're used to having like 3 screens going on.
Yes. And for you, there's lenses now that are more like an office lens. And what they do is they widen that narrow section of the hourglass, and then they make your distance and your reading a little smaller so that you have wide. But that's the trick with finding a good optician or optometrist that will tell you about this, ask you what you do with your eyes, and then kind of advise you towards that pattern of lens.
That's awesome. Wow. Okay. So then you talked about some of the things you want to get on your glasses. And so a lot of times it's kind of like when you buy a car, they're like, you need to get the warranty, you need to get this, you need to get that. And it's all like a scam for them to just extract more money from you. So when you're going to get your glasses, and you talked about blue light filters, and obviously we all look at screens a lot more than a generation ago, whether it's like on a laptop or on our phone. What are the must-haves on, we'll stay away from sunglasses for now and just talk about non-sunglasses. What are the most important things to have on them?
So now they're making materials that are clearer and shatter resistant. Back in the day, we just had polycarbonate and glass. That was kind of the two. And now we get into these even better plastics. And so if you're tough on your glasses, like a lot of people who work in construction, or they have to slide safety glasses over their glasses, they want a really superb scratch coat, and they want the anti-reflective. Anti-reflective helps you as the patient wearing them because you're not seeing glare coming from the back of your lens, and everybody else can see your eyes because they're not getting the glare from the front of the lens. So that, I would say, is your base. When it comes to blue light, they're now integrating that into that material as well. It's not necessarily a coating. And it's important because that particular wavelength of light gets through all the way through to the back of the eyeball, to the retina, and can shake and rattle those nice little cells and can do damage over time. So anybody that's on a computer more than 4 hours a day, I said it's part of your life. You just need to wear. It's like if somebody was going to be a basketball player, you wouldn't tell them, oh, it's fine to wear flip-flops. You're doing this for a huge section of your life. You need to be wearing good shoes. So it's more like that kind of a fit with the blue light.
Is there any way you could get like how you get like with menopause, you can get like your hormones tested? Is there anything that you can do to kind of get tested to see like how much damage the blue light has done? Is there anything out there like that?
Absolutely. So you can measure the cells in the back of the eye, and there's many layers to the cells. The retina is what takes all of the light rays, turns them into electrical impulses, and sends them to your brain and gives you vision. It's quite phenomenal. But that process of taking in light and turning it into something else, that taking in of light does damage. Just like our skin, it does damage to those top cells and gets a little further down too. There are scans, they're called OCTs, or ocular coherence tomographers. They will give us a cross section of the center part of the eye and tell us how all of those layers are doing. And it picks up many diseases, but it definitely tells me if I saw something changing in a 32-year-old, when I expect to see those changes from old age at like 75, then I would have to say it's from computer use. We need to be fairly aggressive about blue light therapy.
Does like a typical optometrist do these types of scans in their office, or is it something you go to like a radiologist for?
It can be included. So the shift in routine eye exams is happening because before, we're looking into someone's eye through their pupil. And if you had like a dark room and you took a flashlight and you kind of looked up and down the walls and on the floor and you look all over and things look pretty good. That is how we've always done routine eye exams. But now we have the technology, and a lot of times because it's not included in your reimbursement from insurances. Right. So most places will charge a fee to do this retina camera. And it takes a picture. It's like turning on the lights all at once in the whole room. You get to see the whole thing. And you can look for any of those problems. With the OCT, there's now retina cameras that incorporate an OCT. And you can start asking for that too. Again, it's not usually covered in a routine eye exam. So it's one of those, like, you feel like you're kind of being upsold, but it's really not an upsell. It's just deeper than what we can see through a microscope.
So it's the opposite of a scam. It's something that you proactively ask for if you've spent a lot of time in front of a screen, whether it's a laptop or a phone.
Yeah.
And just, like how I think of those things is you get a baseline. It's kind of like a bone scan for osteoporosis, right? You want to find out like, okay, I just turned 53. So it's like, okay, I want to know like, where am I at? Do I have a problem? Am I on my way to a problem?
Yeah.
Or am I in good shape? I have a feeling that I've looked at screens for the past 30 years. I probably have something that I need to look at and take care of.
Yeah. And it's probably subtle at this point. And that's why those scans, that OCT is kind of like an ultrasound of all the different layers. It's so helpful because it's more preventative. If we wait until I can see it through your eyes with a little flashlight, like that view, it's already pretty progressed.
Right. So now you talked about, also with the blue light, I have some friends who don't have prescription lenses, but they go to their local pharmacy, Rite Aid or CVS, Bartell's, and they buy blue light glasses off of the shelf, kind of like readers that they just buy. Are those effective in terms of blocking the blue light? Do you recommend something else?
In my view, it's better than nothing.
Mm-hmm.
So how much protection do you want is basically, where that is. So if I have no problem with someone grabbing a pair of reading glasses that works for them, has some blue light on it, it is protecting you. But if I were to see something, so let's say at 53, the scan comes back that some of these cells are damaged, then I would say, let's not go with those over-the-counter ones. Maybe let's go into something that's prescription. Make sure that you've got exactly what you need.
Okay, that's helpful. So one of the things, we talked about in like the prep is that with readers that you get over the counter versus readers that you get prescribed to. So maybe you could talk a little bit about that and why it matters to maybe invest, given how important your eyesight is.
Yeah, so hardly any of us have exactly the same eyesight in both eyes. And so it's a little bit off. And if you buy a pair of reading glasses over the counter, both lenses are the same power. So your eyes aren't necessarily lined up at the exact same spot at the exact same time. So it's harder for them to work together. So what I usually hear from people is that they might have the right power for one of the eyes and they're getting along okay, but they're getting headaches. And that headache is because the eyes are kind of competing. They focus in, they focus out, they focus in. They just can't figure out where that best vision's at. And so their eyes are constantly working. Like if I asked you to do, you know, knee push-ups all day long, it would get sore and you'd want to stop. So I, usually ask people, how are your reading glasses treating you? And they're like, oh, they're fine. I said, well, how are your eyes doing? Do they get tired by lunchtime? Do you have to take breaks? Are you rubbing your forehead, which is a huge sign that there's eye strain? And if it's those things, then you want to get a prescription, because now the prescription will add whatever power is necessary for each eye to bring them into focus at the exact same spot. So they're helping each other out.
So that actually, in my mind, sparks something else. So we have a lot of parents in this community. So there's also advocating for their kids. What do you think that parents need to know that they don't naturally know about eye care? Other than like their kid has headaches, maybe it's time to go see, to get glasses.
Yeah. The most important is that you need a good eye exam before kindergarten. And the reason for that is kids have this amazing ability to squeeze their lenses inside their eyes and they can see everything, but only for a little while. So if you're farsighted, your best vision is to see the moon. Everything else closer than the moon, they have to flex their lens to see. Well, they're going to be fine doing some activities, but not for an extended period of time. And a lot of kids will get away with it till they're like 6, 7, maybe even 8. But now the demands at school are so much higher for up close that everything's becoming kind of blurry. It's going in and out. They're making letter reversals. Their math skills look like they're going down. It has nothing to do with the math. The letters or the numbers are just getting blurry. And so if you get this eye exam early on and find out, oh my gosh, my kid is farsighted, they've never mentioned any problem with their eyes, you're going to use glasses when you're doing all the little details and they'll see much better.
Wow. So thinking about that, like someone might be diagnosed with dyslexia or something like that. And it could be just something as simple as getting your eyes checked and seeing if you need corrective lenses.
Correct. Yeah. It is a big part of it. We'll see, school nurses will flag a kid, say, they're a little blurry. They'll come in, do an eye exam. Or if they're thinking that there's some sort of deficit when it comes to reading or writing, then they'll usually ask for an eye exam. Primary care physician will ask for an eye exam. But the hardest part with the screenings is, like I said, some kids can just squeeze those lenses and you have them cover up one eye and they squeeze really hard and they can get it and they pass. And so that's why getting a dilated eye exam before the kindergarten is super helpful.
Okay. So then if you're thinking teenagers and tweens, so I just spent the weekend in New York with my nephew and niece, and my niece is very much into her makeup. And obviously there's lots of people who wear makeup. I have to think that there's probably some things to keep in mind as you're using eye makeup.
Yes. So there's little tiny glands. Their pores are on that inner lid area, right? So you have your eyelashes coming in and then that flat piece of skin and then your eyeball. That's where the glands are located. They're really long and skinny and kind of tortuous, and they produce oil with every blink. You actually squeeze a tiny little droplet of oil and then your lid spreads it over your eye. But if you are clogging those with makeup, pretty soon the eye starts to get dry. The front surface starts to get little tiny areas where the cells have dehydrated and there's little cracks that are forming. And now if any bacteria gets in the eye, the body can't rinse it away. It'll get into that little crack and you get an ulcer. The other is you'll see blepharitis, which is the clogging of the glands, but the glands are constantly kicking out the cloggy stuff and it's getting stuck on the lashes. And you'll see people that kind of have flakes in their lashes. And that's a mixture of bacteria and your oil. And and it just kind of lives there and makes the eye very uncomfortable, very dry. Sometimes you get styes. So removing makeup is really important.
There's so much in the beauty and cosmetics industry. So is there anything that a good cleanser will have, or is it just as simple as just like something like soap and water and that's it? I mean,
yeah,
all these people are like, oh, it has this, and
right. So with the very basics, I tell my patients, if you don't want to do anything else, just do baby shampoo and water on a washcloth.
Right.
And I pick baby shampoo because it's for sensitive skin and sensitive eyes and all that. So that works. I might stay away from the lavender scented one.
Right.
You don't really need that in your eye.
I'm thinking about that. I'm like, does it matter if my eye smells like lavender? I'm not sure.
Yeah. And then you can go all the way to where what I do, and I buy OcuSoft lid foam or Ivisia. These are soaps that are meant for the eyes. They usually have a little bit of oil to help moisturize as well, so you're not stripping the oils from the eyes. And I use that to clean my eyelids and take off my makeup. And I'm kind of doing two things at once. I'm killing off any bacteria that might be in that area, but I'm also getting rid of the makeup and having clear skin and lashes.
Is there anything, so like there's stuff for like what, making your eyes look more alive, like stuff you put maybe under your eyelid, things of that nature. Is that stuff good, bad, or okay if it only has these ingredients? What are your thoughts on that?
That one I'm a little torn about. The skin is so thin and delicate right under the lid and right on top. And so you don't want anything with a steroid, because the steroid can penetrate through there, actually get into the eyeball, and it gives you a little bit of risk of having elevated eye pressures, which can cause glaucoma. So no steroids on the eyelids. Then when it comes to the moisturizing, it's oils, oils, oils. Anything that's an oil is great. Vitamin E means, I know people who do olive oil or castor oil. You just want to make sure it's clean and, not full of bacteria. But I'm not too specific on moisturizers. You just don't want to get it into the eye.
Yeah, one of the things I'm always worried about when I put something above my eye is that if I sweat or something like that, it's gonna get into my eye, and then that is going to be very uncomfortable. So that's something.
Sunscreen in the eye is awful.
Yeah. Yeah, for sure.
I think for sunscreens, I like anything that's mineral based and zinc. The interesting thing about mineral based sunscreens is they don't expire nearly as quickly because it's a mineral. And it does a great job of protecting. It doesn't damage the eyes. It's some of the others that you have to be a little bit careful of.
I hear the sunscreens in Europe are way better than what's allowed here in the US. Is that fact?
I don't know if it's what's allowed. It's just Europe doesn't allow certain things in there, like titanium dioxide. I don't know if they allow that, because if you give enough to a rat, it gets cancer. So I think they're just more strict about what they're able to put in there. But I buy my sunscreen from Australia, and that's because they're better at it.
Well, they have to be.
Yeah.
Any other habits? You've talked about blood vessel health. You've talked about blue light filter glasses, cleaning the eyelids after your makeup. What are the other things? You talked about sunscreen. So sunglasses have to be a part of this.
They're huge.
But leaving out the prescription aspect of it, what are the things that people need to look at when they're buying sunglasses? And does the coating expire so that you need to get new does the UV expire that you should be getting new sunglasses even if your prescription hasn't changed every certain amount of years?
Yeah, so the UV protection is embedded in the lens, so it's good for a very, very long time. Over the counter, let's say you go to Target and say, these are super cute, I love these. If they don't have a sticker that says UV ABC, I I probably wouldn't buy them because they're just tinted. There's not UV protection. But if they have a sticker, then absolutely go ahead and use those. And I still have that philosophy is something is better than nothing when it comes to UV protection. Tint is not better, but UV of any kind is better than none. You can get, all the way into the high end things, which was more of like your Maui Jim and Ray-Ban kind of thing. And what they do is multiple layers so that the lens itself protects every single type of UV. It also creates different darknesses so that it mimics a pupil in the center. Maui Jim, it does a wonderful job with that. So you actually get better, crisper vision because they have so many layers in there and they create that depth of that focus area. But anytime you go outside, even on a cloudy day, having UV protection saves the lens in your eye so that you don't get cataracts quite as early. And it definitely saves your retina, which is something that's very hard to repair.
So do these glasses have UV protection typically? Would these glasses typically have them?
Probably if they're a prescription pair, then you're probably looking at about 80% UV protection with just those. Yeah.
Okay. All right. That's helpful. Is there any like foods or beverages that are definitely like the eye is like, yeah, give me more of that?
Well, foods for sure.
Right.
So I have a little food list and it runs the gamut, but it's all of your micronutrients that we don't really talk about when it comes to, when you go in for your physical, we don't really talk about a ton of micronutrients. We don't test for those on a regular basis. But your selenium, that kind of thing, lutein, zeaxanthin, these are big names in the eye world. And so you can take a vitamin, which is great. And if you have macular degeneration, we definitely want you on those vitamins. There's been a 50, maybe it's even 60-year study at this point on macular degeneration and what foods seem to help, what nutrients seem to help. But in general, you're looking at your green leafy foods. Brazil nuts and sunflower seeds are on there, kiwi and melons. There's a whole plethora of foods that are good for the eyes.
Okay. All right. That's good to know. So you talked about macular degeneration. Is that something that's genetic? Is that something that just happened? Is it both? Is it genetic and environmental?
You are correct. It's both.
Okay.
Yeah. So we may not be able to prevent the genetics, but we can catch things early now. And the FDA has approved a couple of dry macular degeneration medications now. Before, we only had medications for wet macular degeneration. The difference between them is dry looks like somebody sprinkled salt in the retina and made it all bumpy, which is hard to see through. And the wet looks like the bumpy part that spilled liquid. And that liquid is really difficult. It's very visually devastating.
Are most of the treatments, whether you're talking about glaucoma or macular degeneration, are they topical treatments? Are they pill treatments? What is generally the way that it works?
So cataract surgery, when you do the exchange, that's literally making a teeny tiny incision in the eye and swapping out the lens. And that surgery has become absolutely amazing. You're looking at, 20 minutes or less for a lens exchange. Yeah. When it comes to glaucoma, there are some lasers that create heat in the front surface of the eye that open up the outflow channels. And sometimes if you do that, you don't even have to use eye drops. But the main treatment is still eye drops for that. When you get into your retina, there aren't any eye drops really that you can use for macular degeneration. It's injections or the preventative stuff when it comes to wearing the glasses, eating the foods.
Okay, got it. Before we get into menopause and autoimmune, any other types of conditions that you see a lot of that you want to talk about? I'm thinking maybe glaucoma, something like that? I have a couple friends with detached retinas. I don't know how common that is.
Yeah, detached retinas, they happen spontaneously for some and sometimes because of trauma. And so if you ever see a whole bunch of floaters, like you just walked into a room full of bugs, or a curtain coming down over your vision, or you're missing an area of vision, I would love for you to go in and get seen in the next 12 hours. Chances are it's not a retina detachment fully, but there is a chance it is. And a lot of my patients that on a Friday, they'll notice this. They're like, we'll just see if it gets better by Monday. By Monday, they've permanently lost their vision.
So you should go to an ER.
I would go to your local optometrist, ophthalmologist.
Well, I mean, if they're not open, if it's like a Friday or a Saturday, something like that.
Yeah, so usually there's an on-call provider with your eye docs. All of your eye professionals will have something on call if it's after hours. And they may send you to the ED because sometimes the ED will have providers that can dilate the eye and take a look. But a lot of times what happens for me is they go to the ED says, I'm pretty sure they have a retina detachment, and then they send them over to my clinic.
Right.
So if you can get into your eye care professional first right away, that would be the way to go.
And is it fair to say that if you call the office of most eye care professionals and you're like, these are my symptoms, they're going to be like, oh yeah, we're going to figure out a way to get you in?
Yeah, right now.
Yeah, like it's not a 911, but it's kind of a 911.
It's like an eyeball 911.
Yeah. So I mean,
yeah.
Okay. No, that's good to know in terms of those symptoms and why you should err on the side of getting it checked out as opposed to just waiting and see, because obviously the consequences can be massive and they can't be undone.
Yes, we would much rather look in the eye and go, you know what? It is some floaters. There's no rip or tear, no retina detachment. I'm so glad you came in. We'd so much rather have that scenario than the person who follows up 3 days later and they've lost vision and we're not going to be able to recover it.
Wow. Okay. And then glaucoma.
Mostly genetic, but there's also times like diabetics that have uncontrolled sugars. Their blood vessels will start to grow kind of erroneously and can cause glaucoma. Trauma can cause glaucoma. Steroid eye drops, steroid eye creams can cause glaucoma. So getting that eye pressure check is really important because you can't feel your own eye pressure. A lot of people, when they say my eye feels like it has pressure in it, it's actually just eye strain. It's not their actual eyeball pressure. There's lots of muscles that attach to the eyeball. And if those muscles are constantly squeezing, they're going to feel like it's pressure, but it's different than what eyeball pressure is. So air puff is often what's used, or you touch the cornea very, very, very lightly, like essentially just the tear film with either a little blue donut or sometimes this tiny little wisp. It almost looks like a little hair. And all those ways that's how you can check eye pressure. It's super important.
Yeah, my optometrist does the puff test. I know that. It feels a little wacky, but I know that's what
it does.
And then there's this other thing we talked about. It's presbyopia. Is that the right way to pronounce it?
Yep. So presbyopia is not really, it doesn't mean nearsighted, doesn't mean farsighted. It isn't astigmatism. It is the loss of the ability to flex the lens in your eye. And so for people who have great vision everywhere, 40-ish is a little rough because all of a sudden they're holding things further out and they've never seen blur before. And for them, it's devastating because they can't see. For those of us who've worn glasses since we're 10, it's just a change in prescription.
Right.
But it's because that lens is just not flexible anymore. And that's from absorbing all that UV light our whole life.
Okay, interesting. So let's go into menopause, right? And what people need to be thinking about as they're in perimenopause, or if they're trying to get ahead of things. They don't think they have symptoms, but maybe there's some underlying things that are happening. Like we know that we lose estrogen as we get into perimenopause, into like, your late 30s, early 40s, that process starts to happen. What happens from the eyes perspective?
Most of the problems with dry eye in women are from hormones. So as our testosterone decreases, which happens earlier for women than it does men, our little meibomian glands, those little ones that are right at the lid margin and are long, they decrease how much oil they're producing. And so the tear film has this oil layer on the outside, a watery layer next, and then protein and nutrients that are on the cornea. Without the oil layer, then the watery layer evaporates much faster. And pretty soon we just have dry eye. So eating oils is helpful, omega-3s, cleaning the lids to make sure those little glands are open, heating the eyelids to keep that oil viscous, it doesn't get too thick. So if you have oil that's kind of cooling off, if you think of like candle wax, and as it cools off, it gets harder. Well, now you can't get it out of the gland. And so heating it with a topical hot compress is helpful.
Okay, so eye open and you put the compress on, or eye closed?
Eye closed. Yeah,
okay.
Eye closed.
Mm-hmm.
And so that's a big one for menopause.
So what about, like, you hear about collagen as a thing? So is it a thing, or is it a scam, or somewhere in between, like taking collagen supplements? What's your take?
I wish it was more effective than it is.
Mm-hmm.
It does help a little bit. And there's all sorts of topicals now. But the skin is so thin around the eyes.
Mm-hmm.
So people who are going to look like they have more wrinkles are eye rubbers or are contact lens people. Because if you've been pulling on your eyelid and lifting your eyelid every day, for your whole life, that skin is going to stretch out a little bit more. So there's not a lot we can do for the eyelids except for some minor surgical procedures to kind of tighten that area.
Would you say that's more cosmetic?
Yes and no. If the lid bags a lot and the lid margin is now falling away from the eye, their eye becomes really watery and drippy and red and irritated and dry. And that becomes less of a cosmetic, but more of a medical necessity to lift and tighten that bottom lid.
So that brings me to something else we talked about in our prep call, was around the fact that you can get to an eye doctor through your medical insurance. It doesn't always have to be through your vision. So maybe you could talk a little bit about that.
Yes. If your concern is only that my vision is blurry, or I just want to check up to make sure everything's okay, you're talking routine eye exam under vision insurance. But if you come in and you say, man, the vision in this eye is kind of cloudy, or it's different in this eye than it is in this one, and then we look inside and it's a cataract that's starting, or it's dry eye that's creating some blurry surfaces, that's all medical codes, all under medical insurance. Through your medical eye exam, you're not going to get a glasses prescription for the most part. You're getting the health of the eye checked. If there's any pain, redness, watery, discharge, any of that, that's all medical.
So that exam was an OCT?
The OCT, the ocular coherence tomographer, like an ultrasound, can check front surface things and also the retina. And we will do that if we find something in those areas that need to be scanned. So if I look in the eye and I think, that doesn't look quite right, then I'll order an OCT and we get this in-depth look of the back of the eye.
Is that something that would be covered under medical or a vision plan in your experience?
Medical.
Okay. All right. So that's helpful, because I find that vision plans are kind of not so great.
Yeah. I mean, they're out there so that you can get glasses and contacts.
Yes, exactly. Like, that's about it. But I think that if you have something else, I think it's important for people to know that they can actually come to you and file it through their medical insurance, or at least ask the question to you, like, oh, is this something that I could submit through my health insurance versus my vision plan.
Correct. So like Medicare patients that need their eye exams, like, oh, I have diabetes. I was told I need an annual check. That's all through their medical. If they wanted a glasses prescription, they have to sign a form that says, I understand that my medical doesn't pay for this. This would be an out-of-pocket expense. So medical doesn't cover everything. Vision doesn't cover everything. And you just, no matter, medical is a little bit more all-encompassing when it comes to eye health than the vision insurance has been, in my experience, but that's largely because I worked at hospitals.
Yeah, it makes sense. I mean, the Venn diagram I think it's just a general state of our healthcare system where you have to be able to triangulate disparate sources of data in order to make sure that you have the coverage that you need and get the care that you want.
Yeah.
So you talked about decreasing testosterone with the dry eye. You're hearing a lot more about with menopause, how there's different types of hormone replacement therapies, whether it's the patch, whether you're taking a pill, whether it's something topical. What can people do in that space in terms of hormone replacement therapy specific for the eye, and what's a scam?
Yeah, so when it comes to the topical, there is a compounding pharmacy here in Seattle that I use that puts testosterone in essentially an eye cream, like a nighttime eye cream, and you put it on your lid, and the testosterone soaks in and tells those glands to start producing more oil again. And for most of my patients that have tried it, they absolutely love it. They swear that it's working for them. And there's a few that are like, I tried it and it just didn't seem to work. Now, those people might not have the same underlying problem. Maybe they have enough testosterone, but the glands were actually clogged. So the topical is there when it comes to hormones for the eyes. When it comes to everything on the inside, it actually affects our skin. So if you can take supplements that help skin, like collagen, it can help with some of the droopiness. It's just not going to be a big change. It's going to be subtle. When it comes to our blood vessels, we have estrogen receptors all over in our blood vessels, and they function better when we have estrogen. And that's why like our blood pressure starts to go up as we get older. It's not always because we're gaining weight. It's just that those blood vessels inside of our bodies are not doing the same thing because they don't have estrogen. So I am a big proponent of taking HRT. And I would say if your primary care physician doesn't feel comfortable with that, that's just not one of their specialties, then to find one, because that's a different universe than what is your red blood cell count, your white blood cell count, your cholesterol, we just haven't been very good about incorporating both of those on our annual exams.
No, that's great, because that's one of the things I always talk about here with people I bring on is that if you're finding that someone doesn't believe you or isn't like listening to what you're having to say, then go find someone who does. And particularly with all of that now debunked HRT study from 24 years ago.
Totally.
I think it's really important for women to advocate for themselves. And, we talked about earlier for their kids, if they're not getting the care that they need. All right. So couple more things. And this has been fantastic. And I'm really grateful for all your knowledge. And I know there's so much here that I'm going to have to splice and dice for little clips. And that's a great problem to have. We talked about getting that baseline exam for kids before kindergarten. What would you say is the right time in terms of getting eye exams, whether or not you have a prescription as you get older?
Yeah. So, you've got the before kindergarten. I would do another one in like 3rd and 4th grade, right before you hit puberty. Again, while you're in puberty, which is different ages for different people. Right around that 20-year-old timeframe is when you start to see some change, especially if all of a sudden they are going into college and staring at screens more than they did before. You're going to start to see some changes. From 20 to 40, if you're healthy, inside systemically, you're healthy, your eyes feel great, I would say every 2 years is just fine. If you have a strong family history for early onset glaucoma or macular degeneration, or you're using screens more than 4 hours a day every day, I would say that annual exams should be the way to go. And then when after 40, for sure every year. And if you start picking up some of those diseases, like my diabetics with higher A1C, I see every 3 to 6 months.
So if someone is under the age of 40 and has one of those risk factors, or they wear glasses all the time, I mean, would you say that they should go more frequently than the schedule that you listed out?
If their vision is stable and they don't have any diseases, I would say every 2 years is fine, because wearing glasses is just kind of, are you short? Are you tall? Are you nearsighted? Are you farsighted? But if you have a family history or something has popped up on an exam prior, then every single year is when you should go in.
Yeah. So another thing we talked about before was around, you can have cancer in another part of your body, but it can very easily work its way to the eye. So it sounds like that's another thing to be very, you may think like, oh, I have breast cancer. I can't prioritize my eye exam because I got to go through my chemo and radiation treatments. But it sounds like, if anything, you need to be more vigilant.
Yeah. So unfortunately, the eyeball is where things metastasize to. So breast cancer, lung cancer, colon cancer, and skin cancer. Those are some big ones. And you won't feel a tumor in the eye. The inside of the eye doesn't have pain receptors. And so eventually it will block vision. And then people come in and they're like, there's something wrong with this eye. Well, that's a metastatic tumor. If you can catch a tumor when it's tiny, which is what that retina camera, when you get that full picture of the eye and you go, there's a little bit of a dark spot right here. Then you can OCT that spot and get thicknesses. And if I see something new, it's one of those where it's borderline suspicious. There's something just not quite right about it. I bring them back in 1 month. We repeat the same photo. If there's any change at all, I'm sending to Harborview to our ocular oncologist.
Yeah.
And they can they can do cryotherapy, tiny little radiation. It doesn't necessarily mean the eyeball needs to be removed. It can be treated. But it's important to figure out, where did it come from?
Right. Okay. One last thing before we sign off. When is a good time to figure out if you should get LASIK or not?
So a couple things with LASIK. It is best usually for nearsighted individuals, which means when you take your glasses off, you can see up close, but you can't see anything far away. And the cornea, which is the clear part on the front surface where you put a contact lens, has to be thick enough to remove enough tissue to correct your vision. So when you go in for that screening, my favorite time frame age-wise is 24 to about 34. Because in our 40s, we're back into glasses again. So if your whole goal is to get rid of glasses, I wouldn't do it in your 40s.
Right.
But from 24 to 34, you're very stable for the most part, and you get all this time without glasses or contacts. I had LASIK way back in my 20s. I think I was 23, and it held steady all the way until it was 46. So I didn't have
my husband. It was like roughly around that same time, and then he needed readers.
Yep. And the lens in my eye is getting a little thicker, eventually leading towards cataracts. And so I'm slightly nearsighted again, so I can see you at the computer space clearly. But if I wanted to see something up close, I'm putting on a reader. And when I drive, I'm wearing distance glasses. So LASIK was wonderful. It does make dry eye a little worse because the little nerves are being severed. And so if you have existing dry eye, treat that first. And then be prepared to treat it for a little while afterwards too.
All right. Is there anything else that you think people should know when seeking care for their eyes that we haven't covered? Anything you want to add?
Well, I mean, I think it's an essential part of our body. And so I would treat it well. Make sure you get those eye exams, just like you go in for your physical. Make sure that you're using quality lenses to protect your eye from blue light and sunlight. And then it sounds weird, but eat healthy for your eyes, because if there's eye damage in the retina, it's very hard to reverse.
All right. Well, this has been an action-packed and really informative conversation with Dr. Hollenbeck, and I'm very grateful for your time. So thank you very much. Again, this conversation is not a patient-provider relationship. This is just for informative purposes. For those of you in the Seattle area, we will have Dr. Hollenbeck's contact information in the show notes. We'll have some of the other things that she mentioned earlier around certain supplements or things that she takes for her eye health, and we'll go from there. So Dr. Hollenbeck, thank you so much for joining the Go Long Show.
Well, thank you for inviting me. It was wonderful.